How do we reduce the cost of that care? Is it reasonable that you're paying as much as you're paying for that care? We should be always asking questions and saying, how could I do better?
You've been sparked by the DPC movement, or the direct primary care.
And that is the problem with the system. It's built on gain. It's built on selfishness.
It has its practitioners, its doctors, nurses on a tight leash controlling them. DPC erases all of that. Welcome, everybody, to the podcast this morning. I've got the pleasure to speak with Paul Reynolds. He's a family nurse practitioner in the Denver area. The Daily Apple Clinic is actually located in Denver. Paul, welcome to the podcast.
Thank you. Glad to be here.
Typically with these interviews, we dive into your daily life. Like what is it as a nurse practitioner do you do every day for the Daily Apple Clinic?
So we're a small independent clinic. So we obviously see patients. We see people from birth to death, the very youngest to the very oldest folks that come through. Since it's our own practice, we also have to manage all the business that goes with it. So that's more my bailiwick. I take those responsibilities on. And I see patients, and my wife, Monica, also sees patients. And then we have another person who helps us with answering phones and taking care of some of our social media stuff, a little bit of marketing things. And that's about it. It keeps us quite busy, putting it all together and kind of keeping it running. It can be frustrating and a little frightening at times. It's a pretty big job. It takes a lot to kind of keep it all going.
Yeah. Well, you're wearing multiple hats every day.
Right.
Yeah. So you mentioned two other employees, your partner, your wife, also a nurse practitioner, correct?
Correct. Mm-hmm.
And then administrative and marketing person to help the days flow, schedule in, schedule out, and things like that.
Correct.
Cool.
Right.
So pretty small, not a lot of staffing overhead. Right. You're at one location in Denver, is that correct?
That's right. Yep, just one for now. Hoping to
one
grow.
For now. And then so let's talk about your growth. You've been sparked by the DPC movement, or the direct primary care. As a family practitioner, that's well within your purview to get into and to dive into. So just help us understand from your perspective, what is direct primary care, and how do you see yourself in that landscape?
Right. So direct primary care has been around for, I guess you could really say people have been chatting about it, talking about it since maybe the 1980s. I think some of the folks that describe it say it officially started in somewhere around 2007. So about 17 years ago. The goal was to allow people to access providers more directly. The idea was they couldn't get a hold of folks when they needed to, if they wanted an appointment, if they had a question, if they needed access in some way. It was going to provide better access. The problem was they were trying to figure out how to merge in all the other things that people needed and wanted, and to coordinate care by lots of different types of people. And specialties, in addition to services that fall really outside of the purview of direct medical care, medications, imaging, things that we just don't do, eye care, dental care, things like that. So how do you coordinate all that stuff if you're really just living in this one little box over here? So that probably is one of the biggest challenges of direct primary care. But the goal was to say, okay, look, I'm doing an awful lot of stuff over here as a PCP, or primary care provider, or physician. We're not physicians, but people make misunderstand or change the way that acronym is used. But we can and do a lot of things that could cross over into other areas. So if we could do an awful lot of things and then be paid a reasonable amount and be able to develop good relationships, good connections with our patients, we can simply provide better care and then make a decent living at it. And I think that was the original impetus from the very beginning. It was really just a situation where some folks got together and said, this isn't working out for us. We need to come up with a better solution. And the way the current system is set up, care has been consolidated, it's been aggregated, it's been brought together and monetized. And so we're simply losing track of that desire to do better for the greatest number of people. It really, we've just gotten lost in this giant mix. And so folks were saying to themselves, we can do better. When I first went to medical school, I'd say within the first week or two of being there, I knew absolutely 100% immediately I could do this better. I was convinced I could do better. I could create a better system. I could treat people better. It's a function of being able to see behind the scenes, start to understand who the personalities are that are involved in this profession, this tradition, how it's set up, how people enter it, how they are able to stay in it, the organizations that are involved. I just learned an awful lot as I processed through those situations and had to make decisions for myself about what it all meant to me. I didn't start medical school until I was 47 years old, much, much older. I was way, way over to the right on that curve. And I finally left medical school when I was, I believe, about 50, something like that. So very old as I went through it. And so I had a very different ethic, a very different support system, and a very different stamina level. I was just older. It requires a tremendous amount of effort and dedication to get through medical school, residency, those processes. That's one of the reasons that doctors fight so fiercely for their profession and for what they've accomplished. They are incredibly deserving of any income they earn and any accolades they receive for the work that they do. It's a hard process. It takes a lot out of you. You sacrifice a great deal to be able to wear that white coat and be that person. And in that process, you can lose a lot. And I think most of us do lose a lot. And the same thing can happen through the nurse practitioner programs as well. They're certainly much shorter. They're condensed. They cover a different set of material, actually approach medicine from a different perspective. So go ahead.
Yeah, Paul, you said a lot there, and I kind of want to dive into a few of those things. So sure. At 47, you were admitted to medical school.
I think right in there somewhere. Yeah.
Somewhere around there. Yeah. So I guess what were you doing before that, and what led to the decision to go into medicine, at least at that level?
Sure. Yeah. We could have a discussion about late bloomers. We could talk about people who do different things over the course of their lives. I started out, went to college. To sail ships in the merchant marine. I ended up with a third mate's license as a deck officer. And so I wanted to sail ships, see the world, and carry cargoes all over the planet. And I thought that was just a cool and adventurous thing to do. Within a few months of getting out, I realized I wasn't having enough adventure, and that my age, my capacity for physical endurance would wane rapidly. And I had a lot of friends who had been in the military. My father had been in the military. and there was a 6-month window at the time where you could sign up for Army Special Forces right off the street. Sign up for, not necessarily be guaranteed a slot. You had to pass all this stuff. And so I said, I think this is what I need to do. I felt that this was right for me at the time. So you go through a basic training program. They assign you an MOS. You go through jump school, learn how to do the parachuting thing. You go to Special Forces school. At the time, it was different because you were just being pushed on through. There were only about 1,600 Green Berets at the time, and they were trying to increase that number. So anyways, finished that program, got out. Then within a few months, I was asked if I wanted to go to combat dive school. So I did that. You parachute into Key West, and I became a combat diver and was assigned to a scuba team where I had previously been on a rucksack team. And then we mostly deployed. I was in 7th Special Forces group, so we deployed to Central and South America. The Caribbean was our AO, and we had a variety of missions, foreign internal defense and direct action. So I did that, got out, and tried to figure out what I wanted to do. Went to business school for a while at the University of Washington. I love business, but I didn't feel it was getting me where I wanted to go. We were doing we were sitting in class one day and we were doing a project, and this, we had this binomial thing that was set out there, a calculus program. We had all these different variables in this system, and I said, so you're telling me basically you drew a line on the map and you're thinking things are going to continue in that direction. That's what all that means. And he said, yep, that's pretty much it. And I just kind of closed my book. I said, you guys are making this way too hard. And so I just lost interest. And I said, well, okay, what am I going to do? And so I ended up opening some businesses in different places. I had a restaurant down in Florida. I did a lot of work up in Alaska for about 7 years. I managed some properties for some people and worked as a ship's agent up there for a while. And while I was up there, I just really started taking a hard look at who I was, what I wanted to do. I went through a teaching program to become a K-12 teacher, finished that program. Really enjoyed it, enjoyed working with kids and helping people, started working more with a local church there and volunteering more. And really, as an older person, I said, how am I going to give back? How am I going to make a difference in the world? And came back to the lower 48 just due to the difficulty of living. I was on a small island in the Aleutian chain for most of that time and a little while in Kenai. And just through an introspective process, I said, I think medicine could be a really great opportunity for me to combine my desire to do something really great in the world with helping people at an individual level. I really enjoyed just being with people, connecting with them. But I also like developing consensus and trying to create something better together. And that to me is kind of what business really should be about. So I went to my family doctor and I said, I think I want to get into healthcare. What should I do? And so he said, well, you could be an EMT, you could be a CNA. And I said, well, what does it take to be each one of those? And he said, well, an EMT is going to take you a while, but to be a CNA, you can go somewhere right now and do it. And at the time, I didn't have any sense that I was in it for the money. I never really was. And so I said, okay, I'll go be a CNA. CNA is a certified nursing assistant. It is the absolute bottom job in healthcare. But it allows you to touch people's lives, to help them in powerful ways. It can be a very demeaning world out there. But I was happy to learn those lessons at the time. It didn't bother me. I felt that my life was about learning, and there was a lot that I could learn there, and I did. So I did that, started kind of working my way up, and then I said, I think I'll go be a PA, a physician assistant. But as I began to research what was possible, I said, nah, I think I'm going to go ahead and see if I can get into med school. And so I applied, and by the grace of God, they let me in. And because not very many people get in at an older age, they just don't have that stamina. They don't have the focus to support. But they decided that I would be a candidate that they wanted in. So I attended med school. My wife at the time was having some problems with some programs she was going through, so I took a break so I could help her with her program. Then I went back and just became disillusioned with the process, with the people I was meeting, with their attitudes, and with the things that really truly motivated them. And I felt that those things were simply not things that motivated me. And I wanted to raise it up a level, and I wanted to surround myself with people that I thought had more altruistic values and that weren't going to allow themselves to be used by or beaten down by the system. And it definitely exists out there. It's hard for people to get through that process and still maintain their deepest levels of empathy, and I'll even say integrity. We need to be truthful with ourselves and always make sure that we're doing the thing that we think is right for us. And we always, we must never live at the expense of others. And the problem is we pretty much all do. We live and other people help us in our lives. And so, but we shouldn't do that intentionally, and we shouldn't do that with an aim to take advantage of other people, manipulate them. And that's just inherent, endemic in healthcare. It is, and it just comes down to what choices individuals are making. And so I wanted to be around individuals that would possibly help me be a better person myself. And so I went off into the nursing field. I found a way to get into some programs with short training times, and went through one of those in North Dakota. And then I finished up their nurse practitioner program a couple, 3 years later. And from there, we moved here to Denver and started learning with an internal medicine clinic here. And after doing that for a couple of years, we opened our own clinic. We did that because I always wanted to do it better. I always thought I could build this better, and obviously using someone else's system was never going to allow me to achieve that objective. So the goal here with this clinic was always to provide better care for people, be able to take time to listen to them, hear what was really going on, and really try to come up with optimal solutions for optimal outcomes. The goal was to think bigger, get out of the big box production medicine mode and model, and really start focusing on people with an overarching goal to helping them improve their lives in general. The goal is to say, who are you? Why are you on this earth? What are your purposes? What are your gifts? What are your talents and abilities? How do I help you identify those and really figure out which ones matter the most to you and which ones can have the greatest effect on the world? And how can I then be a support to you, a mentor, a muse, whatever you need? And then how can I help you get over the speed bumps of life? You get sick, you get a cold, you get the flu, you cut yourself, you hurt yourself. How do I help you realize that they are merely speed bumps, and I'm here for you. I'm going to do what I can to help you get through that, and encourage you to get back up on the horse and start riding. And let's pick a point on the horizon that is the right point for you. And let's figure out which points are the wrong points for you or anyone, and get you pointed away from those things, and get you steering the ship back in a direction that's going to get you where you want to go. Hopefully, everybody has their own path, their own journey, and we can only assist. It's a horses and water issue. I generally know which water is the best water and what you should and shouldn't be drinking. But medicine is an imperfect science. Completely, totally. We do not know all the answers, but we use research, we use protocol, we use information that we've gathered over hundreds of years, and we just try to do the best we can. And beyond that, it has to do with the connections we make with people and trying to understand who they are as individuals and then helping them choose for themselves. It's always a collaboration between us and our patients in terms of figuring out how we can help them see themselves and understand themselves and then make good choices for their futures.
Thanks for humoring me with that. I think it's important for our listeners. It's important for me to understand. You basically just laid out, this is why medicine is the option I chose. Compassion, right? You talked about being an educator. You enjoyed seeing those children, right? K through 12, those children learn and grow, see their potential. Your service in the military, you wanted to support, and even your curiosity and exploration. I again, thank you for sharing that. And it all boils down to how can Paul, right? How can you do what you think is best to provide a quality service for others, and that ultimately led you to what you're doing now. Cool. Thank you. In the provider space, as an owner and operator of a clinic, we're going to talk about some medical struggles and maybe some day-to-day struggles, as well as the perks of what you do. How critical is it for a patient to have a primary care provider like yourself? Yeah. So how important is it for that established relationship?
Okay. So you asked a couple of things. So how important is it to just have one? And then how important is it to have relationship? I don't know if I would call it critical. I would call it important. The truth is that somewhere, and this is something I learned in medical school, somewhere around 90% of healthcare happens in the community. It happens at home. It happens with individuals just carrying on their lives using things that we call like 6-pillar health, just doing conscientious smart things, if you will, not doing bad things, not getting into trouble, and following the things that we know that are kind of good things to do. Eat the right food, get plenty of rest, make sure you're not too stressed, get some exercise, hang around good people, don't drink the dirty water, don't eat at the restaurant where you're going to get gastroenteritis, don't ride your motorcycle close to the edge of a cliff. Just do smart stuff. That's the 90. We then, in a clinic like ours, will generally help folks with about another 9% of their health care. And that is the colds and the flus and the injuries and anything else that's coming up. That is what those doctors work so hard to be able to do. It's just a tremendous amount of knowledge. The last articles that I recall reading, the amount of knowledge and research that happens in healthcare doubles every 73 days. I believe a new research article is written about every 26 seconds, I think. And I believe if a doctor were to try to read every single article, so you can kind of do the math there, every single article out there in every medical journal, I think they're supposed to have to read about 5,000 articles a day. So it's an impossible task. And so we aggregate medical knowledge. We try to pick out the very best. There are perverse incentives there. Most of it's funded by people who want to try to make money to sell drugs or some process. They want, bigger cardiac center at their hospital or whatever it is. And so you got to be really, really careful. There are a few doctors out there that are really very good at reading the literature and really understanding where the bias is and getting better information. And so we all at least pretend that we're trying to do that at our very best ability to create both effective and efficient care. We gather that information together. because nobody can remember it all. In medical school, they call it the penguins will jump off of the iceberg. Eventually, you just can't remember everything that they're throwing at you. They call it drinking through a fire hose. And there's lots of places where you have to do that. And
Yes, I've heard that.
so what we do is we put it all together, and then nowadays we have, it used to be a PDR. It was a physician's desk reference. It was a book that sat on your desk as a doctor, and you would open it up and you'd look up that diagnosis and try to figure out what you should do. If you couldn't remember, you wanted to reinforce that knowledge. And actually, they have an online service, and now there's Up to Date, or God forbid, Medscape, or something like that. It's just there's stuff out there that we refer to and we learn from, we grow from, because it's always changing, and we have to stay abreast of the knowledge out there. They talk about doctors being lifelong learners, and all medical practitioners should be. So that's the 9%. And then there's this other 1% over here, that's stuff that a guy like me couldn't do. We're just not trained for it. And so we rely on people who did decide to go get that specialty training, or it's something that would require emergent care, that sort of thing. We can do a lot of things, but if someone is very ill, bleeding out, they got a broken bone, their brain's not working, they're not breathing, if they have a bad belly, or they have some kind of an issue that I simply can't take care of, I'm going to refer you to somebody who can, or I'm going to try to. And so, but direct primary care, to segue a bit, the goal there is for someone, so maybe that is happening. No one's going to change whether that happens or not in the world, but people will have perceptions about what might be emergent care, hospital care, specialty care. They certainly use the internet, and we actually encourage that. And so they may have a lot of different ideas about what they may need. And so we can be a filter for them. We are not a gatekeeper as a DPC. Within the current system, the gatekeepers are designed to really reduce costs, to keep people from doing something or spending money that the system doesn't want to spend. And so we rather are a filter and say, how you doing? What's going on? Can you tell me what's happening? And is it something I can take care of? If it is, I say, great, come on down, or let's take care of it. It's included in your cost. It's already been paid for. I'm here for you. You got my cell phone. You got my text. That's what I'm here for. However, if that bone is sticking out of your arm, you've probably already gone to the ED. But if it's something in between, or we're not sure, then at least I have the ability to help you figure out what you need to do or what you want to do. The DPC model allows for some catastrophic coverage for that. We will help you figure out how to get that, something that works for you. But then you save so much money using our DPC clinic, say $85 or $95 a month instead of $700 a month, that difference can be used by you to save money to prepare for those possibilities. And as you get much older, I will say eventualities. And so the goal is for you to first do the smart thing, get the care that you need, get a trusted advisor in your life, and then save money, and then develop a program and a system whereby you can protect yourself if you might need that. The truth is that we spend very, very little time in the hospital over the course of our lives. The average person spends around 18 days in the hospital, and that includes 2 when you're born. So, and that's 4 visits. Almost all of that care happens after you're 60 years old. Most of that happens after you're 65. Most of that happens after you're 70. It's all very commonsensical. We all know how life works and how it happens. So the goal is allow people to recognize that 99.94% of your life is not spent in the hospital. 0.06% could be potentially. If you and I are working together over the course of your life, I can get you skewed to one end of that spectrum. I can get you to a point to where you won't go to the hospital as much as everybody else. Instead of 18 days, yours might be 10 days or 12 days. And so the goal is to help you think about how to live a better, healthier life. And it's far more far less about that thing happening to you than the quality of your life as you live it. That's what's most important. We're focused on the 99.94. We're focused on the time you spent out of the hospital and how you are doing something amazing with your moments. That's what matters. That's you. That's the you that we love, that we care about, that we want to see flourish. And that's what we're trying to help folks do.
Paul, that was a beautiful explanation. We've seen the charts. Everyone's probably seen the charts in the healthcare space where it's like cost of health in age brackets. And it's just, under 10, it has some cost. And then it's essentially a slow incline until 45, 55. And then they group everything 55 and plus kind of together. And
right.
That's where most of, we're talking Western medicine consumption in the United States. Most of that is consumed at the 65 plus. That's where all of that money is being spent. Do you know of any data that supports, reducing hospital days, reducing those later year chronic disease spend?
In terms of how DPC has improved care? Oh, yeah. There's tons of data out there. Yeah. Some of the first studies, some of the best studies, I think they were like 2014, somewhere in there is when we started getting some of the better data. All of the videos and the cartoons and stuff that we've made for our website have all been pretty meticulously researched. Obviously, I didn't want to throw any numbers out there that weren't true or that were skewed. The problem with that is they're numbers. They're just numbers. And that's what I tell people when I show them their labs. I'm like, don't get excited. It's a little high, but it's just a number, and you're you. Let's not get too excited. But most of them show significant reductions in the need for high cost care. Then it becomes debatable as to just whether or not there's real value there. And when I say value, I'm not, is that person going to help you? Is it going to be a great thing that you went to the ED with that broken arm? I think so. Or whatever was happening to you. However, how do we reduce the cost of that care? Is it reasonable that you're paying as much as you're paying for that care? And the cost varies tremendously across different facilities, even though they're really using pretty much the same protocols because of the way the system has been aggregated and because we all share that information as best we can. And we want to provide good care. We are required to provide the very best care that we can. When someone in the medical field gets in trouble for not providing care, it's because you didn't follow the protocol. You didn't follow what you should have known you should have done. And so that's where the paranoia for those people exists. But we shouldn't live that way. We should live simply wanting to do the very best that we can. And so we should be always asking questions and saying, how could I do better? What should we be doing?
Thank you.
Yeah.
Yeah. No, that's awesome. So a couple of things you said there. You talked about knowledge or, the use of the internet. You encourage patients to come prepared with questions, to come prepared with, let's say they're having some sort of chronic pain or chronic disease. How, if you have an experience with a patient that we'd love to hear it, how has using the internet in an appropriate way helped you and a patient come to an agreeable treatment plan or a diagnosis and then solution after diagnosis?
Happy to have people do their research. Anybody who doesn't want somebody to go out and take a look around has a control issue. We need people to feel free to gather information. In my office right up here, I have about a 44-inch screen on the wall. That was put up there very intentionally. It's designed to be large enough that people that are sitting on that table back there, they can actually read stuff. It'll be big enough for them. If they're sitting in the chair that's right there, they can also read that stuff. And then so I have two screens and I can go back and forth. I can pull stuff up there for them. And so we literally go to the internet many times to help them figure out what they want to do. And it's not about just like some medicines or, hey, this is what doctors are doing, although I do that stuff too. I use UpToDate extensively here, which is one of these things where they have just bunches and bunches of doctors that in their specialties, they put information in there and they describe causes and treatments and, all the epidemiology that has to do with things. And then you can get lost in a rabbit hole in there, but tons of information. So I'll pull that up and I'll say, this is relevant to your case, I believe. What do you think? And let them read it. There it is. There's our information. There's the secret. There it is right there. But I, for instance, had a patient come in, had allergies, and they also work in construction and they cut tile for a living. And previously they had said they were wearing their mask. And then so I said, okay, how's the mask going? And, well, I'm not wearing it. I'm like, well, maybe that's your problem. I said, no. I said, we're going to get on the internet right now and we're going to figure out why you're not wearing your mask. And so we pulled up a bunch of masks, found a bunch of filters and said, what do you think of that one? I don't like that one. How about that one? Yeah, I like that one. It's about helping people get over the speed bumps, helping them get over those things that are keeping them from taking care of themselves. And sometimes you need a different environment or just a different day. They woke up right, they had their coffee. I don't know. But our goal is to offer solutions. People come to us with problems. They're seeking solutions. And so the goal is not to think that the answer is going to be in a pill or some liquid or some treatment process. The treatment may simply be, you need to go for a walk every day. You just need to drink a little more water. It could be something very simple, but that takes time. It takes a desire, a willingness to hear their story. And that's one of the things that direct primary care offers, time. And then you just have to have the heart to be part of it, be part of their lives, to connect with them, to just be somebody that they can trust, and then have the background and experience to be able to offer solutions that might work. Sometimes they have an idea that I haven't thought of, and so let's pursue that. Let's take a look at that and see if that might work for you. The truth is that we want to know what works. We want to know what works for you, and given all of the data and all of the solutions that are out there, a dozen of them might work for you. But we want the one that's going to work the very best. And if you're not engaged in that solution, if you're not committed to it, if you don't appropriate those ideas, ain't no way it's going to work for you. You won't be what we call compliant. And
Sure.
and so we use the internet. There's the short answer. Absolutely. Lots of ways. Yeah.
Well, I mean, just that the construction worker example was a fantastic example of that. Falls into the 90% that you were saying earlier. Yes. That's right. That's not medical care. That's 90%.
It is,
but because they didn't have their proper PPE for the job, et cetera, it's causing a medical issue. And so instead of, you need some sort of breathing treatment or a pill or liquid to stop the symptoms of whatever he was having, you spent the time to say, well, we've talked in the past about your PPE use at work. Are you still compliant within that? No. Okay. Why? They're not comfortable. It's hot. It's sweaty. I can't breathe as well. Okay. Well, let's instead of me, here's your prescription, go to the pharmacy and you'll be fine symptom wise. We're not really treating the real cause. You took the time to get him back compliant, to help him in that 90%, diving into that 90% with him.
Right. And we're
cool. I like that.
Anything, whatever's going to work for you. We know about those treatments. They can be a great idea. Absolutely.
Yeah.
So we want to figure it out. But in medicine, the problem is we should be always seeking the upstream solution. And this is something I really stuck with me in medical school. And the things that I've read is that if we're not figuring out what's happening upstream, you're never going to solve the problem. Never. So is it, why aren't you wearing your mask? Is it that you have a susceptibility? Is it that you've moved to this new location and now your susceptibility is aggravated? Did you change jobs? Whatever it is. But those are questions that take time and a willingness to work through all of the things that possibly could be going on. And most providers now are limited in how they can interact with patients. They're only allowed typically to discuss one diagnosis at a time per visit, and that's kind of how the fee-for-service model works. You get paid for doing something to a certain level of acumen and effort, if you will, reading labs, talking to certain people, consulting, whatever you have to do. And then that changes the way you're reimbursed by the large entities who basically own the providers that contract with them. And maybe 5 or 6 years ago, you probably heard a lot about rationing care. I don't know if you remember that. It's the national models. The NHS was kind of getting hit for that. Okay. And there will always be rationing of care when someone's trying to limit their expenses, their costs. Then the people on the other end are going to work it from the other side and say, well, I'll just have more visits. There are medical models within the traditional model that absolutely are based on figuring out how to get more people to come in on a regular basis. They actually target Medicare patients because they know they can do this continuous chronic care management and they can charge for those types of visits over and over again. Both people are going to work for it, what I described before as a perverse incentive. So there are people who will say, oh, people are going to come to your DPC practice and there's going to be people who are going to overuse the system. They'll come to you whenever they want. You gave them your cell phone, for crying out loud. And I'm like, yeah, a few people may, but that is simply an opportunity for us to help that person. And if you don't go into medicine with that desire, that heart, that attitude, in my opinion, you really shouldn't be here because those folks are going to show up on your doorstep eventually. And you have to be ready for them. And they come with sometimes very complicated, very complex histories. And they can be damaged. They can be traumatized. They can be people who really need a lot of help. And so the goal is to try to figure out how to help them. I may not be able to, but very few people will access care in that way. Most people will simply go, okay, I'm paying this amount of money. If I were doing this, it would be 3 or 4 times as much if I went for a visit. Geez, Paul's only charging me a fourth of that. That means he's giving me way more care than I deserve right now. And so, they're pretty reasonable about it. And the goal is to make it easier for them because we piece it into smaller chunks that enable them to afford it. And that's the goal. The goal is to recognize how little of that giant amount of money gets pushed into the PCP pile and how much PCP provides to overall care. And when we start giving the people who are really providing the highest value care reasonable compensation for the work that they do, I am convinced that this won't do anything but help the people involved. And that means the people who are paying for it and the people who are receiving that care and the providers who are providing that care. It allows them to do their work more conscientiously, more authentically, and allows them to have the time to become the person that they remember they wanted to be when they first started, and unlearn all of the junk and the pain that they went through as they were beaten up, beat down in the process of becoming that production manager, and really getting back to the heart of medicine.
Yeah. So with that, the heart of medicine being on your mind, and And then what you said previously about, every 30 seconds or less, a new article is written with new research, yada, yada. There's no way you can be today up to speed. We're practicing medicine about 10 years in the past. I don't know if that's 100% accurate, but in some regards, we're practicing. Well, I'm not a practitioner. You're practicing medicine based on research that has been done in the past. And so with that, help me understand kind of what drives protocol decisions. At what age do I need to come in and get my screening for this or get tested for this? What drives those decisions in the medical community?
Research is constantly being done. There are large organizations, societies, if you will, that try to manage that, usually in their own interest. There are some that are more broad-based, USPSTF, United Preventive Services Task Force, something like that. And so what you're looking for is data that has come together in an unbiased way. And you want to find people who are looking to not be skewed by any other information than what the data truly tells them. And so when we read these research articles, we are constantly, there's a dozen different types of bias that can exist inside these articles. And so we're trying to get to the real information. And the truth is that normally it gets played out over time. When you're talking about a population of 330 million people and stuff's getting done to them all the time, right? And pretty soon, or either people are going to raise their hand and say, this is what happened to me, or someone's going to go, oh yeah, look what happened to that guy over there, And so we actually get research articles that are actually done on individuals. Someone says, hey, here's like this anecdotal situation, and they will, have a study that they do on some one person. But the idea is, hey, we've learned something new, and I would like to share that with someone. You run into personalities, you run into egos, you run into people who are like, I'm going to write 50 articles and everybody's going to see that I'm out there changing the world through new knowledge. Or I'm somebody who really is good at understanding these things, and you should look to me to answer your questions. Or I'm an expert on this, and so I'll find this little silo that I can live in, and I'll be living up in the upper floors of that silo. But the goal should always be to say, okay, what did that guy figure out? What did that lady figure out? What did that person figure out? And we generally have meta-analyses that combine similar types of data and similar types of studies, and then we ask ourselves, how did they compare? How did the information sift out of all of these different studies? And so we have different ways that we do studies that make them more reliable, where the data is less likely to be biased, and we feel that we have better information. And then we just add it all together. Everybody does the stuff that they do over time, and we all just kind of watch and see what happens. That's the truth of it. If someone gets in trouble for something and they do something that harms someone, we immediately begin to look very carefully at what happened. Was it an individual decision? Did they do something intentionally? And how can we do better? When I was in the shipping industry, it was the same thing. As soon, nobody worries about anything about the laws and the rules until a ship bumps into another one. Then all of a sudden, everybody wants to know what happened. And then they change the rules. You can't turn left when you're doing that. And if there's this going on, you can't do that. And so it's the same sort of a situation. We're all just trying to figure it out as best we can. And in general, I think we do a pretty good job. When I was in medical school, I believe they told us, they said, well, in 5 years, half of everything that you know or that you've been taught here is going to be wrong. That's what they told us. And I don't know if that was completely true. Maybe it was because I wasn't paying close enough attention, but it seems like most of the stuff that we talked about is still fairly valid. Definitely details have changed, and certainly we have learned new things. There's no doubt about it. That was quite a while ago. But But in terms of what we use, it's the aggregated information and what's been proved to be correct. If you step outside of the lines, you're asking to be questioned about what you're doing. Someone's going to see it sooner or later. There is a fairly careful process that most providers will exist in because they worked so freaking hard to get where they are. They are not going to give that up. They don't want to lose their credibility. They don't want to lose their position. They're very tight organizations that we live inside of here. And and there are boards that are established that are supposed to be regulating that. There's a big deal about how doctors want to manage themselves and then other people want to manage them. But the truth is that if you're a physician within this system, you're a domesticated animal. Sorry, you're on a leash. And you are owned by the system. They are managing us. The role of DPC is to allow some more freedom to practice and to kind of stop the insanity, if you will, and allow patients the care that some of us think they truly deserve, and allow providers to practice in a way that some of us think they truly deserve, and to change the system so that people aren't being crushed by a system that really has been taking far, far, far more money from them and really our society than they ever should have. It just consumes a tremendous portion of our potential, of our resources, and that could be channeled back into the productivity and the joy of living that people are missing out on right now because they don't have enough money to pay the rent or to have a dog or to go for a walk and take the time to do things that are good for them, or just try things that they probably should be trying to experience, but they're held down by the stresses and responsibilities that have been placed on them because of the complexity of our social structure currently, and the money that we're having to invest, or we think we need to invest to live life. We should be living far more simply than we are. We should be allowed to do that, and we should have far more control over the money that we're earning, in my opinion.
Yeah, and more control over how it's spent. You talk about the industry, as maybe as a machine or an animal. It owns. It has its practitioners, its doctors, nurses on a tight leash, controlling them, or telling them under which guidelines they can offer care. DPC erases all of that, and like you said, people need to live a little more simple life. Well, that's what DPC is. It's a more simple way to practice medicine. And it's more relationship based, as you were talking about.
Yeah. So the argument, would be or could be, well, oh my gosh, these guys are just going to be out there doing whatever they want. For heaven's sakes, there need to be some controls in place. You guys can't practice like that. You can't just do whatever you want. You need us to make sure that you're following those protocols. I would agree. I would say yes. If the protocols are beneficial, if they help patients, if they get us where we want to be, then there needs to be some means established whereby they would be kept in check. But go ahead.
Yeah. So if there needs to be some balance. I guess where in the industry did we take a turn to the extreme of loss of autonomy for the physician, loss of autonomy for the practitioner, and lack of control on the patient side?
Yeah, I think it's been a frog in a pot thing. I don't know if it's really been like something that's happened. You could really say, yep, right there, or even this time frame. Probably over the last 100 years or so, the old old time doctors, physicians really kind of came into their own as we developed our deeper understandings. We began to study more, and the Fleischner times, they established some of the very first hospitals that we had in our country, but you could point to the Kaiser Foundation and how they got started out in California back in, I think, the 60s. They were a large consolidation, and they were one of the first really big organizations to go to employers and to actually structure their entire process as they gathered employees together and then accepted fees together with them. And then they started to call it, insurance. It wasn't really insurance then. They were just paying for care. But then they got big enough to where they could include enough specialty providers. They kind of just included it all. They created their own hospitals, their own facilities, and that's kind of how it happened. And then everybody, if there's a big pie out there, everybody's going to get a fork out and figure out how they can get a piece of it. And so they said, how do I make this something I can access? And so they started eventually calling things insurance, and it's just not insurance. It's a payment method. It's consolidated care. It's a way of bringing lots of different things together. And so they started calling it by hundreds of different names, and lots of people started getting involved in it. And the more people that got involved in it, the bigger it had to get to accommodate all these people who wanted to enjoy the profit involved there. And so they made it bigger. They raised prices, and they created more facilities, and they created a dialogue around it, a sales spiel, if you will, that informed people about how great it was, how awesome it was, and then they instilled a subtle fear-based tactic in terms of convincing people that if they didn't have it, they would suffer tremendously. There were consequences that were going to be involved, and then they would bring out the outlier cases and say, "Look, here's a person who, oh my gosh, they had this incredible, awful pregnancy, and if it hadn't been for our organization, they wouldn't have survived it. Here's a person who had this terrible brain tumor, and we operated on it, and we were able to give them a much more fulfilling life. They would have died." Well, I'm sorry to break this to all the people that might be watching this, but you're going to die. You don't even have to pay taxes, but you're going to die. And our lives are short. They're tremendously short. We don't realize how short they are. We're just involved in our own little worlds, and we're looking out through the eyeballs that we look out through. And so we have these very selfish, small perspectives. And the truth is that we are absolutely molecules on gnats in the universe. We are just teeny, tiny things, and we only last for a very, very, very short period of time. 13.8 billion year old universe. If we squeezed it into a year for a relatable reference, you and me, this entire country, democracy as we understand it, everything all existed in about the last half of a second of that year. Boom, just like that. All of us, everything, every city in the United States, everything, yep, that quick. So squeeze it down into just you and me and what time I have left on this earth. Nothing, So we need to kind of put things in perspective. Stop thinking that we need to take, we need to give. We need to realize that what little we have is absolutely a gift. And we have the potential to multiply that gift by our choices, by decisions that we make. And if we choose to love people, if we choose to live via our hearts, if we choose to trust, if we choose to tell the truth, if we choose to be joyful, if we choose to be kind and merciful and do good things with our lives, our gifts will expand. We will be able to give away more because, as everybody knows, there ain't no U-Hauls behind hearses. you ain't taking it with you. So the goal here is to try to remember what we could possibly take from this life and how we will be sharing that with others, maybe certainly while we're here, but maybe after we leave this life. And it's only going to be the love that we create and the lessons that we learn here. So the goal is to learn, is to teach, it's to love, it's to do what we can for one another and stop thinking that we have anything to gain here. And that is the problem with the system is it's built on gain. It's built on selfishness. It's built on this attempt to get more. And we should be doing the opposite with our lives. So that's a philosophy that we have here. We share it with folks from time to time if they're interested. It's certainly on our website. But if you're not doing that, I would encourage people to at least consider it, to think about how they fit into the grand scheme of things and the futility of the futile things, and say, wait a minute, is there something better that I can do in this moment with these people, with these relationships that I have? How could I think hard about being a better person, about getting the rest that I need in order to live better? And then that might be about being the most amazing architect in the world. You might be a software engineer that if you lived well and didn't do any of the other stuff, you might create some beautiful, amazing new program. Or you might just be the best mom in the world. You might take tremendous time with your children and focus on how to help them think hard about who they are and where they might go. We see all these things as gifts that are offered to us, and we just encourage people to focus on those what we consider real things and not on the unreal. And I'm sorry, money is a construct. It's just something that was created by people. It's an exchange medium. So why in the world are we getting upset about the oil in the machine? We should be thinking about the gas in the machine itself, and where it's taking us. And we're not focused on the big picture. And so we're hoping that people will see that those little things are the biggest things.
Thank you. Perfect. A perfect kind of summary of what we talked about today. More giving than taking shows your true compassion as a caregiver, as someone who takes care of life. You mentioned it early, from birth to death. That's those are the people you see. That philosophy that you just shared is one I would hope my provider also shares. Thank you. Again, the Denver area Daily Apple Clinic, Paul and his wife Monica are the practitioners there. Clearly, they have a lot to share and a lot to offer for families and individuals. Paul, thank you for your time today.
Okay, Sean. Let us know if we can help with anything else.